Thank you to all who provided questions. They were excellent questions, and you'll see I tried to tailor the presentation to answer as many of them as I could. Without further ado, this year's proposed rule, which they entitle the calendar year 2027 proposed rule, comments on the rule are due August 24th at basically midnight, just before midnight. I did highlight a link, and everybody will have these slides. If you wish to submit a public comment, it's very easy. You just go on the link and you click submit a comment. And in fact, if you want to go to the proposed rule directly, this is what it will look like. You'll actually see down on your lower right submit a public comment. I actually took a screenshot of this, I think on Sunday, so you can see CMS already had 765 comments in, just kind of interesting. And they keep updating that obviously every day. Um, I'm not going to spend too much time. I'm going to move pretty quickly through the PPS part of this, concentrate on the QIP. And in particular, I'm going to concentrate on payment year 2027, which is performance 2025, because you all had a lot of questions about that, and I want to try to address that, but just real high level. This year, the proposed rate is just under $300, 299.55. It looks, if you compare it in parentheses to the current rate for this year, it looks like a nice increase, over 6%. But as Dr. Sam, Raman Sam, and others pointed out, if you let your eyes drift down to the proposed incorporation of phosphate binders, really the bulk of the payment is due to that. Through TDAPA, they included phosphate binders in the rate for 2 years. That's up in basically about 5 months, December 31st, 2026. There are the standard adjustment factors. I've shown you what those are here, except the outlier. I haven't showed you how they calculate that, but I'll show you the adjusters for that. And that's how they get that final rate. And of course, it's always the same for acute kidney injury, which does include home dialysis now. I thought this was interesting. I had talked about this with a couple of the executive directors when I did the executive committee call, but they've rebased the market basket. That's basically the cost of doing business, if you will, in a dialysis unit. And they now are estimating that the labor-related share, whether you all agree or not, is actually going up to almost two-thirds, from 55% to 63. Just thought it was interesting. If facilities ask you and your staff, the network staffs, how do they come up with that 1596? I took this right out of the rule, just put it in a summary slide. I wanted you to have this to know how they got there. Again, they basically used 3/4 of data from 2025. This was the total amount spent in millions on phosphate binders. There was this monthly adjuster, if you will, for administrative costs, and that was obviously included. And then they took the total number of treatments in that period across the country, and that's how they came up with this. They made an adjustment for the outlier policy. They always have to do that. The cost of expensive patients, if you will, that costs more, and that's how they come up with that. Again, may not agree with it, but if you're asked, I wanted you to have that. The adjusters, couple things I wanted to point out. There's a new proposal for low volume, so many more facilities I'll show you will be included in that, even though it was just adjusted 2 years ago. Significant increase in training and the pediatric adjustments going away for those of you that are involved with that. But CMS does have some other options for that. So for training, they're basically proposing an increase of about $43 from the current rate of 95.60 per training session to 138. They said they last updated this basically 10 years ago, And this is how they come up with this. Again, this is what they're using for an RN hourly wage. And they're saying about 2.7 hours per training session. That's how they come up with it. And they will pay it for the first 120 days. This does have to be budget neutral. That's one of those adjusters. Pediatric, they give some interesting stats I've shown you in the first three bullets here. And they basically have two pediatric adjusters, age and peritoneal versus hemodialysis. I have this big yellow arrow just to point out that they are going to increase the adjustment amount significantly for this, with that pediatric adjustment going away for both outlier and case mix adjuster multipliers. And I actually didn't even realize this. Pediatric facilities were not previously eligible for the low volume payment adjustment, but now they're going to be. And moving on to that, it seems like we just adjusted this. We went from the original one size fits all. If you had under 4,000 treatments a year, you could qualify. The adjustment was pretty significant, almost 24% of the PPS payment. It was bumped. And then 2 years ago, they went to two categories, under 3,000 and 3,000 to under 4,000. Now they're proposing to go up to six tiers. And again, I put this slide in so you have it. This is what the tiers look like, how they break down. And this is what they're estimating the number of eligible facilities. For those of you in particular that cover rural areas, this definitely is going to impact several of your facilities. It's a good thing. And you can see these four categories got no adjustment. Now the PPS small, but it will be adjusted by this percentage amount going forward. They do have an interesting request for information about the QIP. They call it a patient reported outcome performance measure, and they've called it dialysis facility discussion of patient life goals, DPALs. I have pretty extensive slides on this that Kelly can certainly share with you. I think the executive director's got them that go through all the questions about this. But they say when this is finished, it'll have 8 items and only take 2 minutes. But they're looking to incorporate this into the QIP as a new measure. So I thought this was important. You should know about it. They're soliciting comments. I haven't really done this justice with this. This is the last RFI. They call it Advancing Dialysis Care, and they have three areas they're interested in comments on: increasing home dialysis among incident ESRD patients, improving access to palliative care, and what they call promoting efficiency by looking at modifying from a PPS per treatment payment to a daily payment based upon a month. Again, they devoted 30 pages of the rule to this. I have a whole separate slide set that, again, I think the executive director's got, but Kelly can make available after this if you're interested. So let me go ahead and just kind of shift gears, dive into the QIP. I think you all know this, but they always make a big deal about this in the rules. And they're basically multiple statutes. So CMS, again, will tell you when they're right, their hands are tied by Congress, and some of what they do, they have to do unless a new law is passed. The big laws, of course, are Social Security Act, MIPA in 2008, which created the PPS and QIP, the Affordable Care Act, tweaked it a little, and then protecting access to Medicare. And what does it require? These statutes require that they have to have measures in these areas. Many facilities ask, why do you have to have a measure covering patient satisfaction or bone mineral metabolism? Well, we have to. What PAMA did is then they said, furthermore, they've got to have measures, if possible, specific to conditions treated with oral-only drugs. This is how hypercalcemia, and now you'll see hyperphosphatemia is going to get in. And then these others follow. But these are all required by statute. So I think you all know this, but it's sometimes confusing, but there's a performance year and then there's a payment year. The performance year is always 2 years behind. So here we are in payment year 2026, which we're wrapping up. Uh, Whether or not you got a penalty or not, you would know it because your PPS payments are reduced. But that reflected performance back in 2024. But simultaneously, we're in performance year 2026, which is going to affect payment in 2 years in 2028. I'm going to concentrate pretty extensively now on payment year 2027, what starts in January. So let me just go over what they're proposing to change for 2029. That would be performance year 2027, what's going to start in January. So first of all, they're proposing take out the hypercalcemia measure. The forum has commented for many years about this. We thought it had run its course, and they even admitted that the measure was topped out a few years ago. And basically, through what they call measure factor removal 5, they're saying they're going to replace hypercalcemia with hyperphosphatemia as it more directly, a direct quote out of the rule, is focused on clinical outcomes. These are what it's going to measure. I've shown you the formula for it. It's a monthly rolling average of phosphorus greater than 6.5. There are a couple of exclusions that they put in. If you want the reference where the CMS got this from, this is from PQM. So you'll have that. You can go to it. They also want to update. I know to Dr. Dave Henner, this has been a big issue. He's brought up year after year in our comments, the bloodstream infection measure. I actually didn't realize that the baseline they use goes back to 2014 data, pretty old. So they want to update this with 2023 data. And they also are proposing to risk adjust for the first time for patient access type, facility, hospital affiliation, number of dialysis stations. Again, if you want more data, this is the link for that. And last but not least, they want to remove two measures from the reporting domain, which essentially means the reporting domain is going to cease to exist. Because if hypercalcemia is being taken out, hyperphosphatemia is going to be a clinical measure. So they want to remove the MedRec reporting measure. They're basically saying costs outweigh benefits. And they want to remove, no great surprise, given where CMS is now with vaccines. They want to take out the COVID-19 vaccination among healthcare personnel. And they say it doesn't align with current guidelines. Again, since the reporting domain, which accounts for 10% of the total QIP weight, is going out, those points are going to get distributed, and I'll show you that. They have to go to the remaining four categories. So, what does Medicare care about? What's important to patients? So, patient experience, care coordination. I highlighted hospitalizations and kidney transplant because I believe, but executive directors, please correct me if I'm wrong, and staff, I believe that a focus on avoiding or reducing hospitalizations and kidney transplant are part of the statement of work for the networks. These are very important to CMS. Clinical care, I try to put this in patient terms in a course of infections being presented. So let's jump to 2027 now. This will be next payment year, which means performance already finished. It was in 2025, and you can see how this breaks out. And what I'd ask you to do, of course, is to focus on the domain counts here. How that's all measured. Because this is going to be critical in terms of how the final score is calculated. So the preview period started, I guess, 9 days ago, and it goes for a month until August 20th. The preview period is going to go till August 20th. And a facility has the opportunity to correct anything that's inaccurate. They can challenge the score that they've been given. And I'll show you how to access all that, but it must happen during the preview period. Or they're going to finally close all inquiries in October. but they're not going to allow you to respond after October 20th. And then there can be a back and forth between the facility and CMS. Again, 56 points has to be reached, and then no penalty is given to a facility. But if a facility gets less than 50 points, and I've shown you the breakdown here, this will be the amount of penalty. Basically goes by 10-point increments. If a facility gets 25 points or less, they're going to get the maximum 2%. I assume most of the facilities have already gone on and looked, but I just wanted to stress that we are in that window now. We've got about a little over 3 weeks left. Something that is confusing, although when you think about it, it makes sense, but there are measures where facilities want to get higher rates, and I've shown you those here. And then there are measures where facilities want to get lower weights. And of course, things flip. So the benchmark goes from a high value to a low value, and the threshold, which is sort of minimal performance, goes from a low value to a high value. The reason this is important, and I'm stressing it, because what I'm going to show you shortly is, by the way, are the patient pictures blocking out anything on the slide? Are our picture our visual things for the attendees, are they blocking out you seeing the slide?
I don't think so, no.
Okay, good, good, good. I wasn't sure and I wanted to make sure. Um, this was one of the questions that was asked. Is there a minimum number of patients that has to be there for a facility to get tagged for a measure? And the answer, of course, is yes. For most of the measures, it's 11 patients. If you have under, you get a pass on that particular measure. There is also a question that was asked about, well, what's the adjuster for small facilities? In general, most of the facilities, it's 11 to 25 qualifying patients. And then there'll be a mathematical adjustment to your score. Basically, you're going to get a bump. So if your score is, 8, it's going to be increased for that particular measure. There was another question I know that was asked about what's a qualifying patient. And so I wanted to put this in here for you so you all understood. So the first bullet's kind of interesting. It has to be Medicare fee for service. Of course, if you think about this, just stop for a moment. This means that patients with Medicare Advantage are not included in the QIP. This is really becoming an issue. And I think we may see this change because Medicare Advantage accounts for over greater than 50% of the population at most dialysis facilities. But right now, it's only Medicare fee for service. I've given you the other issues here. They have to have end-stage renal disease, not acute injury, has to be a participating facility. They have to be registered through either the 2728 EQRS or claims data for at least 60 days. It has to be a full reporting month. Some measures are, in fact, adult only, or I put the little asterisk, so they define that as 18 years or older. They have to be on dialysis, can't be an incident patient for at least greater than 90 days. They have to be at the facility for at least 2 months. And certain measures you will be taken out if you're uh, 75 or older or in SNF or on hospice. I know another question that came up was how does a facility qualify to be scored? Well, you must have at least one measure in at least two domains. Then you're going to get scored. If you have less than that, you're out. You will not get a total performance score unless you get an extraordinary circumstances exception because of a disaster or another complication, and then you can be out. So hopefully this addressed a couple of the questions. Um, this actually is a very valuable slide that I enhanced. Some of you may have seen this. This came off of CMS's QIP presentation that they gave, I think, about 2 weeks ago. And I added some context to the slide. I defined for you achievement threshold, benchmark, and improvement threshold. I also showed you the mathematical formulas for a facility because I know this was a question many people had. Calculating an achievement score, which would be 0 to 10 points, or calculating an improvement score, 0 to 9 points. It's interesting, and this is why I kind of dwelled and I put that slide in from CMS about directionality, measures where we want to get a higher number versus those where we want to get a lower number. Because if you think about it, mathematically, your formulas have to flip around. Otherwise, you're going to have a negative number. So anyway, I gave you everything you can kind of go back to. And I showed you how do you get 10 points for the measure. That's the maximum you can get for achievement. Obviously, if you equal or exceed the benchmark, you get no points. If you're less than the achievement threshold, that's that 15%. And then how do you improve? Basically, and I'm going to show you an example here. So I'm going to show you some data about the long-term catheter rate just to try to walk you through this. So this hypothetical facility got a score of 0. Why did they get a score of 0? Well, for the current period, 2025, they had a catheter rate of 6.95. Not bad, well under the achievement threshold, a little above the benchmark, but for their improvement rate, which was 2024, they actually were better. They were 6.05, so they can't improve, so they got 0 points. So this facility can only achieve, CMS will give the facility whatever they score better on. So now I'm going to show you how did they come up with this 8 points. So you can see for each of these measures, CMS puts a measures manual out. You just Google CMS QIP measures manual, and you can get this, and it'll give you definitions, description of numerators and denominators, inclusions, exclusions. There are QIP performance reports. When you go in to get your reports through HARP, you'll have access to all these documents. But for long-term catheter rate, this is the definition. I've given you how they define the numerator and the denominator and what their inclusions are and their exclusions. And then I just quickly try to walk you through the math. So, of course, this is a low measure. So basically, it's 9 times the achievement threshold minus the performance rate for the facility over the achievement threshold minus the benchmark. And when you stick those numbers in off that previous slide, this is what you come up with. This is the final calculation. This is what the ratio looks like. When you just do the math, voila, that's how they ended up with this facility getting 8 out of 10 points for that particular measure. And you can go through the same calculations for each measure. So this is this, again, hypothetical facility, and this is how they scored on each measure. What they did is these are actually their individual scores for each measure. Probably mathematically, it's easier to see here. So for the bloodstream infection, they got 10 points. That was out of 100% or 100 points, 13.75. So they got 13.75. Here, these were the adjusted weights because they had 3 measures they could be scored on in the clinical care measure domain. And if you add all those up and then you take this percentage, you add these over 10 and you multiply it by the possible points of 38.75, they ended up with 22.03. I apologize. I hope I didn't go through the math too quick. But then when you add these scores up, this particular facility got 68. So we know for next year it's a minimum of 56. This facility did not apply for an extraordinary circumstances exception. They got 68 points. Something I do want to mention, I think people asked about the validation studies. If you are selected, 300 facilities each year will be selected for EQRS or NHHN. You have to provide your data. You really want to do this because if you don't, you can get a 10-point deduction off of your QIP score if you don't submit to CMS. This facility did not get any deduction for this. So their final score was 68, and of course, they're well over the 56, so no reduction. Again, let me point out one other thing. Each domain gets a score, so the total performance score, the normal weighting I had showed you for this, 35% goes to clinical care, 30% to care coordination, 15% to the CAPS, 10% to safety, 10% to reporting. However, this facility, as many will, because you need to have 30 CAPS submitted, did not get a score for that. So we have 15%, 15 points out of 100 we have to distribute. There are four remaining domains that has to get equally distributed. So basically 3.75. So that's how we went from the reporting 10% to 13.75, and you can follow along. I just wanted to explain that, and that's how we came up with this score. So we took out patient and family engagement, and now we have these new point total adjustment times each score, put the scores in, and boom, 68. Um, 2028, basically, we're already 7 months of the year through that. It's 2026 data. Everything is going to look identical. There are not going to be any changes with how these are calculated. Um, these are their projected penalties, pretty similar, but a little better if this holds. We'll know when the final rule comes out. So instead of 25 points, 26 points, and 57 points. So to get it. Um, I'm sorry, a little harder. I misspoke. So 2029, a couple of changes. I told you the reporting is coming out. We have to do something with those 10 points. So what CMS is proposing is not to increase these two domains, but rather they want to take 5 of those points to clinical care and 5 to care coordination, and they're going to make some adjustments. These used to all be 7.5. This is how they want to shift them, and they're now taking hyperphosphatemia and they're putting it in here. So they're lowering these from 12% to 11%. And NHS BSI, NHSN, I only highlighted it because they're recalibrating that measure. So if this holds true, this will actually be better for facilities. It'll be a larger range where there'll be no payment reduction than existed for this current year, 2027 and 2028. So I've shown you what the minimal data requirements are going to look like with hyperphosphatemia included, hypercalcemia out. And what I want to do now is kind of wrap up with how do I avoid a penalty, because there were a lot of questions about this. So what you really want to do is score at or above the performance measure. If you want to know a simple way, how do I know I'm not going to get penalized as I go through the year? If I'm at the 50th percentile of performance, and I'll show you what those are for next year in 2029 coming up, you're not going to get a penalty for that measure. The most heavily weighted measures are the CAPS, the long-term catheter rate, the transfusion measure, and the KT over V, or dialysis adequacy. And I put long-term catheter and dialysis adequacy in red because I'm pretty sure one of the questions that came in was, what measures contribute most to penalties? Those are the two biggies. That's what CMS tells us, is this is where most facilities fall down. For the CAPS, you certainly want to involve patients with your quality meetings. As you know, for 2027 performance year, 2029, the sorry, 2028, the year we're in, the CAPS is being greatly simplified. They've taken out several questions. Maybe more facilities will reach the threshold now of 30 reported. If for the reporting measures, which still go on for 2028, although they're going to be out, really all you just want to report your required data. You don't have to perform, you just have to report. And it's it's really, I think, an easy way to avoid a penalty. And continuous improvement. I know in my many years as medical director, we would have, monthly meetings and we would review the data. Now, I must admit, we were a Fresenius, so they were very good about providing, data every month to us, but it was a good internal check. Were we on target to avoid a penalty or not? So again, the threshold, we've talked about this. That's kind of the 15th percentile. That's the one. If you score below that, then there's 0 points for that measure. The benchmark 90th percentile for all facilities, you score at or above that, you're getting the full points, 10 points for the clinical measure. Um, the performance standard I mentioned, that's that 50th percentile, and that's a good internal check. Am I on target not to get penalized for that measure? What I did is I included this slide for you. So for next year, these are, you can see payment year 20, we're in 2026, but 2027, which a facility has the right to contest. These were the performance standards to avoid a penalty, but I wanted to give you the data which has been finalized for 2028 and is still proposed for 2027. But at least if you want to have an internal check, well, where am I for 2028? Looking at your data through July of 2026, you can have this as an internal check. How do I avoid a penalty? Comply with reporting deadlines for clinical and reporting measures. I think you all know this, but I just wanted you to have this. So for clinical data, here we are now. We're in July. That'll be due September. And you can see for the remaining months of the year. For depression screening, it's not going to be due until March 1st of next year. Same for CAPS attestation. And then for bloodstream infection and COVID-19 vaccination. These are where the deadlines are. One is passed, but we still have three. Um, Again, there's not going to, if it's finalized, the reporting domain will go away in 2029. So starting with next year, there won't be any more reporting, but we don't know that yet. But certainly for 2028, there will be reporting, and I gave you the data elements you have to report for each of the three current reporting measures, at least for 2028. Um, how do I review my results? Well, I hope all the facilities have done this, but you want to, through EQRS, establish a HARP account. There's a facility point of contact, and if you're part of a corporation, a corporate point of contact. I apologize if you already know what the difference is, but I'll show you. There's one report the corporate can get that the facility can't. Once you've logged in at EQRS through your HARP account, you select QIP scores and feedback, and then you can download various reports. And in the next slide, I'll show you details on these reports. There were questions about these, many questions. There's a performance score report. I showed you a mock-up of that for a hypothetical facility. There's a critical patient list reports, and that'll allow you, and this again was a question, try to understand data at the patient level used in those measure calculations. And then there's a performance score summary report that's only available. This is for multiple facilities on a spreadsheet, to corporate point of contacts. Again, take advantage of the reporting period. We're in it now. Unlike comments, you can submit inquiries and challenges through August 20th, 11:59 p.m. Pacific Standard Time. So gives East Coasters 3 more hours. You go to the QIP inquiry screen, select QIP inquiry, create new inquiry. Only facility or corporate point of contacts can submit an inquiry. CMS will email the facility once their inquiry is updated, but you can go in and check. And if there's specific questions for NHSN, I've given both the email and their actual phone number to you. I wanted to give you more detailed descriptions of these reports because they're critical. Again, there are some questions about that Excel workbook for multiple facilities, but both facility POC and corporate POC can apply filters and remove filters. Obviously, the performance score report isn't going to be available until all the inquiries are done. So that'll come out late October, early November, if you will. Then I have a final slide here. I just wanted to share penalties with you. So for 2027, this is what CMS projected they would look like. Pretty significant. About 44% of facilities over 3,200 would get penalized for over 21 million. As unfortunately is the case, independent and small facilities are going to take the brunt of the hit. 2028, this is what they're projecting. Slightly less, 42.6%. However, and then for 2029, we'll have to see, although pretty significant, 47%, almost 3,500 facilities. And what really was quite concerning is a number of facilities moving up in higher penalties. And Kelly and all, I think that's all I have. So hopefully that was helpful. I really tried to address all the questions I possibly could. So many excellent ones came in.
Very helpful, Andy. Thank you so much. If you all have any questions, since this is not a huge group, you're welcome to unmute yourself and ask Andy, or if you want to put your question in the chat, you can do that as well. Although you did a very good job, Andy, of addressing
Well,
a lot of
hopefully,
questions.
Brandy, I know you sent me a lot. Hopefully, I hit a lot of those questions. There were some excellent ones in there.
Does the phosphorus measure account for the increase in penalties in 2029?
That is a great question, Vicky. I actually, yes, that certainly is contributing to it. Of course, remember, it takes time. That's going to be the first year for that measure. We'll have to see how that plays out. But yes, very astute, Vicky. That certainly is contributory to that. I have not, Mary Albin asked a question. Do they have a release date for the DPAL survey? I have not seen that yet. Has anyone else attending have an answer? No? Okay. I just wanted to acknowledge that, Mary. Again, Kelly is going to make my slides available to everyone. There are a lot of links in there, and if you're interested, so you don't have to dig through although I must compliment CMS. They'll have excellent documents available to you in both the measures manual and an explanatory document that when you go in through HARP, you can directly access. You can access those. You can also just go, Google CMS ESRD QIP, and you can get access to all that. But I thought this way you have a one slide set with all those formulas that are in there. Again, I didn't want to overload it with math. I was trying to keep it simple. But in order to understand how do they come up with what they come up with, we kind of had to walk through that. So, Kelly, I don't have anything else, so I can give people back some time, and I think there'll be a recording of this. And I
Yes.
thank you all for joining me today.
Yeah, thanks everyone. I did send the slides to the executive directors and asked them to share it with you all. I'm also going to, once I get the recording formatted, I'm also going to send that out to the executive directors. And please share that with your providers. It'll be posted on our YouTube channel. If you have any questions that you think of later, feel free to email me and I will pass those along to Andy for a response. And thank you all so much for joining us today. This was really great. Thank you, Andy.
My pleasure. Good to see all of you.
Everyone, take care.
Bye bye now.
Bye bye.